Assalamu alaikum. This is Dr. Mariam Al-Abdallah, a professor in orthodontics at the University of Jordan and a senior orthodontic consultant at the Jordan University Hospital. This talk is going to be about growth modification and functional appliances. Our reference is going to be 2 pages from Contemporary Orthodontics, 6th edition, Prophet, 2018, and chapter 19 from An Introduction to Orthodontics by Littlewood and Mitchell, 5th edition. So just to start off with, any orthodontic treatment that is provided for any malocclusion, there are 3 possible options. If we have skeletal discrepancy and the patient is still growing, then we can aim for growth modification in order to correct the skeletal pattern, followed by dental movement, of course. If there is no skeletal discrepancy, or if it's really mild or the patient is not bothered, then we can accept the skeletal discrepancy and go for dental movement only and camouflage. Or if the patient is not growing anymore, if he's an adult and the skeletal discrepancy is severe or moderate and the patient is really aware and concerned with, then we can go for orthodontic surgery. So these are the big 3 options. Now, when we talk about growth modification, then the best way to correct a jaw discrepancy, which is the skeletal discrepancy, would be to get the patient to grow out of it. Okay, so whatever treatment planning we are trying to apply for a patient to modify growth, it's important to have the patient still growing. And then we aim for differential growth of one of the jaw relative to the other by stimulating one to grow faster or restraining its growth and then allow the other jaw to catch up. The principle of growth modification includes the following. First, the timing. It shouldn't be too early and it shouldn't be too late. The second principle is related to the plane of that I'm concerned with, the plane of action that I want to modify. Is it the transverse? Is it the anterior posterior? Or is it the vertical? And the third principle is related to patient's compliance and cooperation. Now, relating to the time, again, it's the most important thing is to have a patient that is still growing. Okay, that means the growth modification has to be done before the adolescence growth spurt ends. So in theory, if your treatment is done at any point up to that time, it should be efficient. So in theory, again, if the patient is in the deciduous dentition means that the patient is less than 6 years of age. In theory, the anterior posterior problems in the skeletal pattern and the vertical problems could be corrected. So why not to start too early to correct the skeletal discrepancy? The reason why is that the patient is still growing. So even if you corrected this problem early, you need to stabilize the result for a long, long time. So you will have a lengthy treatment with multiple stages, a stage in the primary dentition, another stage in the mixed dentition, and the third stage in the permanent dentition, which is a lengthy, unnecessary treatment. In addition, the patient is going to be experiencing adolescence growth spurt, which is a fast and the speeded growth pattern. So you will have relapse, and the result and the success of your early treatment will be compromised. So early orthodontic treatment should not be started in the primary dentition. Now it's only restricted to the mixed dentition, maybe early, maybe mid, maybe late, but it is the mixed dentition stage. Okay. So the opposite, we need to look at the opposite point of view, which means why don't we start in the early permanent dentition? So instead of having a lengthy treatment, why not to go for the permanent dentition and then have a 1 stage or a shorter, let's say, treatment duration? Well, we will have 2 problems. Number 1, as the permanent canines erupt and the second premolars erupt, that means we will have little growth left to modify. So our treatment is going to be not as efficient as in patients who have still plenty of growth to be modified. Number 2, but if we started a bit later, that means we will deny our patient the psychological benefits from our treatment and the reduction of risk of trauma sometimes using our treatment. So not too early, not too late. We need to aim for the growth spurt based on the which dough we are trying to modify growth and in which plane. So different planes. We're going to start with the transverse because the transverse growth is the first to stop, followed by the anterior-posterior growth, and finally the vertical growth. So if you want to expand the maxilla, then it's important to aim for the early adolescence stage, about maybe 10, 11, so early mixed dentition stage. Early to mid mixed dentition stage. And we are aiming to use the mid-palatal suture that is not fused yet, and we try to modify growth at that part of the maxilla in order to expand the maxilla using normal physiological light forces. Because after that age, we will have a more interdigitation of the sutures with the mid-palatal suture and more difficult to open the suture, and we will need heavier forces. The mandible, on the other hand, will have no mid-sagittal plane, no mid-sagittal suture, because both parts of the mandible will be fused long ago during the fetal stage. So we cannot modify growth of the mandible in the transverse dimension. If we need to expand the mandible, mainly this is going to be not a growth modification, it's going to be dental effect. Okay. In the anterior posterior facial growth, in class 2 cases and class 3 cases, we can modify growth of the maxilla and the mandible. For example, in the class 3 cases, we can enhance the forward growth of the maxilla by applying certain forces. And the mandible in class 3 cases, we can restrain and inhibit forward growth of the mandible, where the forces are transmitted to the head of the condyle. In a class 2 cases, on the other hand, we can do the opposite. We can restrain the forward growth of the maxilla, plus minus we can enhance the forward growth of the mandible in order to contribute to the correction of the skeletal pattern. And if you're going to do this, then you need to maintain the results by using the same appliances nighttime, where until growth has stopped or ceased, slowed down. So it's important to retain the results for such cases. The vertical dimension, on the other hand, is the last to stop. For the females, it will continue till late teens, and for males, it will continue till early 20s. So prolonged retention compared to the expansion and to the anterior posterior correction is needed, especially in patients who have long face or short faces. Recurrence of deep overbite can be relatively controlled easier than patients with open bite and long face. It is more difficult to control the patients with increased vertical growth, and you might have an extended length of retention, and even after that you might have some residual growth and relapse of the results. So to sum up, different timing for different problems is important, and palatal expansion and maxillary protraction, which means to enhance the forward growth of the maxilla, are seemingly more urgent in earlier years. Okay, so around between 8 to 10 years of age. Anterior posterior mandibular growth modification is more of a mid-growth activity, usually during the adolescence growth spurt. Let's say between 10 and 12, let's say for females, maybe 12 to 14 for males. The vertical control requires a later approach if it can be accomplished at all. So looking at growth modification to correct skeletal discrepancy, we're going to look at the transverse problems. So if I want to modify growth for the maxilla, I can use what we call rapid palatal expansion, which is a bonded or banded appliance with a Hyrax screw in the middle. Usually the patient will open this screw twice a day for 2 to 3 weeks, and then we will have an opening of the mid-palatal suture and expansion of the maxilla. This is more efficient before the 11 years of age. early to mid-mixed dentition. Now, in the anterior-posterior problem, if the patient is presented with a class 2 skeletal pattern, where we have a prognatic maxilla, then we can use headgear to restrain further forward growth of the maxilla. And this headgear will have the orthopedic effect as long as we control the amount and the magnitude of force, the amount and the direction of force. If the class 2 skeletal pattern is due to a retrognatic mandible, then we can use functional appliances to enhance the forward growth of the mandible. If the problem is a combination of both prognatic maxilla and retrognatic mandible, then we can have a combination of the appliances, headgear plus functional appliance. If the patient is presented with a class 3 skeletal discrepancy due to retrognatic maxilla, then we can use face mask to enhance the forward growth of the maxilla. And this is more efficient between 8 and 10 years of age. If the problem is a prognatic mandible, then we can use chin cup to restrain the forward growth of the mandible. I'm not telling you that these appliances are efficient, but you need to be familiar with the names of these appliances and the mode of action and the indications, okay? Now, if the patient is presented with a vertical problem where the patient has increased vertical proportions with anterior open bite tendency, then we need to control eruption of teeth and we need to control the vertical growth. We can use headgear, high bull headgear, plus minus posterior bite plane in order to control eruption of teeth, as we said, and to inhibit the vertical growth of the maxilla and help with its impaction if possible. Patients with low angles and deep bites, we can use low bull headgear or what we call cervical bull headgear. That will enhance the extrusion of molars. We can also use a flat anterior bite plane on a removable appliance in order to separate the posterior teeth and allow further free eruption of the posterior teeth to enhance and modify the vertical dimension for such young patients. All this is possible, as we said, as long as the patient is still growing. So now we're going to focus on the functional appliances. So in general, the orthodontic appliances could be removable, fixed, or functional. Okay. The removable and fixed conventional orthodontic appliances are mainly used to apply pressure or a force to teeth to produce movement of teeth. But functional appliances, on the other hand, are used in order to transmit, eliminate, or guide the natural forces. Natural forces. What do you mean by natural forces? Forces generated from muscle activity, growth, tooth eruption. Why? In order to eliminate the morphologic aberrations and try to create conditions for the harmonious development of the stomatognatic system. Right? And this topic is covered in chapter 19, as we said. So functional appliances could be removable or they could be fixed. Okay? They aim to use forces generated by the stretching of muscles, fascia, and or periodontium in order to alter skeletal growth and dental eruption in order to correct the malocclusion. Now, these appliances are considered orthopedic tools. Now, the terminology orthopedic is important because orthopedic means growth modification and bone, let's say bone remodeling, okay? And it's important in order to affect the facial skeleton of a growing child. Where did all this started? Well, this started in the 1902 when Pierre Robin tried to treat some newly born children with a severely retrusive mandible. So these patients will have almost no mandible. It's severely retrusive, which will affect the space for the tongue, and the tongue will be pushed backward, and this will in turn affect the space for the breathing. It will cause difficulty in breathing. So what this researcher did was use monoblock in order to hold the mandible forward, in order to bring the tongue forward and enhance breathing and increase the space for the respiratory spaces. And they noticed that for such infants, the forward growth of the mandible was enhanced and it was motivated, the forward growth of the mandible. And thereafter, of course, these patients are later on were called with, they were born with the Beer-Robin syndrome. And they, again, some environmental factors intrauterine caused this restriction of forward growth of the mandible. And the treatment would be, as we said, advancement of the mandible forward. This appliance was further developed by Andresen in the 1920s. And he developed a functional appliance that would hold the mandible forward by the incisor capping and lingual flanges. So if the patient is trying to bite his teeth together, the mandible is forced forward using these two parts, the incisal capping and the lingual flanges. And the only wire that is helping the patient to place the appliance is this labial bow. And the appliance was intentionally made unretentive. So the patient will use as much of his muscle force in order to retain the appliance in place actively. They even added some springs within the fitting surface in order to intentionally displace the mandible, the monoblock from the patient's mouth. So again, this is only to enhance the patient's muscular activities in order to try to maintain, to make an effort, a huge effort to maintain the appliance in place. Why we're doing this? Well, because as we said, muscles muscles will stretch and it will change the soft tissue environment, the stretching of the fascia and periodontium, and it should end up with growth modification. So we need everything to be intentionally active. Now, after that, many types of functional appliances were introduced and used. But the basic principles of all of them was to bring and to posture the mandible forward in growing children in order to enhance the forward growth of the mandible. So the main changes that we're aiming from using these appliances is in the anterior-posterior dimension. These are the main changes we are aiming for. So it is mainly used in mild to moderate patients with mild to moderate class 2 skeletal discrepancy. Now, the mode of action, how these appliances actually work, and the proper timing to use them is still controversial. We don't agree on this topic yet. It's a problem. Now, for you to understand what functional appliances can do, this is a case study from chapter 19. As you can see, this young boy, 12 years of age, presented with a class 2 division 1 incisors classification on class 2 skeletal pattern with retrognatic mandible. Maxillomandibular angle is reduced with increased overbite. Overjet is 12 millimeter, overbite is increased. So we need to have a checklist to know if functional appliance is a good is the correct appliance to start off for this patient or not. So the first question is, do we have a skeletal problem? Yes, we do. We have class 2 skeletal problem. Is it in the anterior posterior dimension? Yes, it's mainly in the anterior posterior dimension. Where is the problem? Is it the maxilla or the mandible? Looking at the patient's nasolabial angle and the patient's labiomental fold, it's mainly the mandible that is retrognatic. So yes, again, mainly it's the mandible. Is the patient still growing? Well, 12 years old, male, most probably the patient is still growing. So can we use functional appliance to correct the skeletal pattern? Yes, we can. So this is the intraoral photos for the patient. As you can see, the patient is in the early permanent dentition. This is the last tooth to be replaced. Class 2 molars and canines here, maybe class 1 here, class 2 canines here, brooklined upper incisors, 12 millimeter overjet, a deep overbite. So as you can see here, these blocks are the functional appliance. This type of appliance is called twin block. And you can see fixed appliances were added as well. So it's a combination of fixed appliance and functional appliance as well, because the patient is in the early permanent dentition. And as you can see, the functional appliance is forcing the mandible forward with good separation between the teeth in order to accommodate the blocks of the functional appliance. And in order to control the vertical dimension. So this is the end of functional appliance, and then the patient is moved to full fixed appliance treatment, and this is at the end of the treatment. So if you look at the patient's profile, our aim was not only to correct the malocclusion by dental tooth movement, but it was mainly to enhance forward growth of the mandible and improve patient's profile. How does these appliances, how these appliances work? What is the mode of action? If you remember, we have three theories for growth. We have the suture theory, we have the cartilage theory, and we have the functional matrix theory. The mode of action of the functional appliances are based, the mode of action is based on the Moses functional matrix theory. This was introduced in the 1969, and later on it was revised, republished in the 1997 in the American Journal of Orthodontics. And this theory would say that the genetic control is mainly expressed in the soft tissues that are surrounding the bone, let's say in general, and the maxilla and the mandible in specific for our topic, functional appliances topic. Okay, so if in theory you modified the soft tissues where bone is growing, then as a result you will modify growth of these structures. And again, the mode of action is one of the most controversial areas. We're not sure what's really happening. But if the patient was correctly selected for functional appliance and the patient was complying with the functional appliance, then there is no question that there will be good correction of the malocclusion. How? We're not really sure about this. But what happens is that when you stretch the muscles and you bring the mandible forward, you will have stretching of muscles, fascia, soft tissue, and periodontium. And this pressure will generate forces that will be transmitted to both teeth and bone, maxilla and mandible. So we will have some skeletal changes and some dental changes. The functional appliances, as we said, regardless of its type, the main principle of its action is to bring the mandible forward, and it should modify growth of the mandible, mainly in the sagittal plane and sometimes in the vertical plane as well, if you're careful about the selection of the appliance and its modification. Now, if you think about it, if you posture the mandible forward, then which part of the mandible will be mainly affected by the stretching of muscles? It's going to be mainly the temporomandibular joint, where the mandible is connected to the rest of the skull. So if there is any growth modification, it will be mainly shown on the condylar head and the glenoid fossa, and then it will be expressed by increasing the length of the body of the mandible later on. Now, the animal studies showed that functional appliances are very effective. They can cause condylar growth, remodeling of the glenoid fossa, some appreciated mandibular growth, and even the strain of the maxillary growth. But we need to be careful here because the facial morphologies of the animals are different from humans, and animals will have no malocclusion to look at. And the functional appliances that were used in these experiments were fixed, so they were there 24 hours. And they had extreme posture of the jaw that could not be applied to humans. So although the animal experiments showed successful results with the functional appliances, but the results should be carefully applied to humans with lots and lots of restrictions and limitations. But we had randomized clinical trials that were carried out in the USA in the late 1990s and in the UK in mainly 2003 by O'Brien. And these randomized clinical trials looked at the efficiency of the use of functional appliances, what exactly happens to the occlusion. And they found that the changes caused by the functional appliances were mainly due to dentoalveolar changes and to more little extent to the skeletal changes. And they found that dentally, we will have distal movement of the upper buccal segment and mesial movement of the lower teeth. We will have palatal tipping of the upper incisors, which means the incisors are retroclined, and we will have more of labial tipping of the lower incisors, which means proclination, in addition to eruption of the posterior teeth in the lower arch. So again, the upper teeth will move distally, the lower teeth will move mesially, the upper incisors will be retroclined, the lower incisors will be proclined, and the lower molars will freely erupt. Usually they erupt vertically upward and a little bit mesially. All these changes will contribute to the correction of the overjet and the molar relationship to class 1. They found that the overjet correction, 73% of this correction was dentally and only 27% skeletal. They also found that the molar correction from class 2 to class 1 molar relationship, 59% of this correction was dental due to dental movement, and only 41% was skeletal. So although the results were a little bit disappointing, but still we were looking at the real changes that accompanied the use of functional appliances. So they are efficient in correcting the malocclusion, but they were not as efficient as we thought in terms of skeletal growth modification and skeletal correction. Nevertheless, we need to look at the results in terms of large variability of response between individuals. So the results that were shown in the studies were the average values. Okay, so we have lots and lots of people that will have good results and improvements in their malocclusion. And if we look at patients with severe skeletal discrepancy, we know that only few and rare cases will have full correction of their severe skeletal discrepancy, but at least those with severe skeletal discrepancy at the end of the functional appliance will be turned into a more moderate to mild skeletal discrepancies, and they will have less need for orthodontic surgery later on, maybe just growth modification, camouflage and fixed orthodontic treatment. Also, the severity of mandibular retrusion and discrepancy, unfortunately, could not indicate the success of treatment. So, for example, it's not true that the more severely retrognatic the mandible, the more successful the treatment using functional appliance. This is not true. And patients that had major changes using functional appliances contributed to 20 to 30%, which is a good percentage of our patients. So if growth modification for the other patients that was unsuccessful and it failed, it's okay. We still have the camouflage and the orthodontic surgery options, okay? Is it worth to try functional appliance in a properly selected cases? Of course, although we cannot predict the success, but we have a very good chance for some patients to have good results. So the key factor to have a functional appliance actively working in a patient's mouth is to have the patients actively growing. Okay, how can we predict growth spurt? Well, this is covered in your craniofacial growth and development lectures. We need to assess growth maturation looking at the chronological age, dental age, height, general physical maturation, growth charts, hand rest radiograph, which is not used anymore by the orthodontist, cervical maturation and cervical stages. Yes, this is more used by the orthodontist. And some studies have shown that there is some favorable changes outside this growth spurt, but we always aim for this period of speed growing, especially if we're looking at mandibular growth modification. Now, girls versus boys, we know that girls mature 2 years earlier than boys. And we have two modalities of treatment. We can start in the early mixed dentition, or we can start in the late mixed dentition or early permanent dentition. So what's the difference? Well, if we start in the early mixed dentition with patients less than 10 years of age, then we will definitely have 2 stages of treatment with a pause. So first a stage of functional, then we wait. It's like a transition stage or retention stage, and then we move to the permanent, fixed appliance stage. If we started later, then we can use a functional appliance followed immediately by fixed appliance stage. So we still have 2 stages, but we don't have a pause. We don't have to wait in between. Both approaches proved to be successful in correcting the overjet. And there is no difference between them in terms of skeletal modification, extraction need at the end of the first stage, or final occlusal alignment. They are the same. But the advantages of an early treatment before 10 years of age is to reduce the risk of trauma by about 40%. Because patients who are up to 10 years of age with who are males with an overjet of more than 9 millimeters, they will have 45% chance of traumatized incisors. So if you start early, that means you will reduce risk of trauma. In addition, you will improve patients' self-esteem and psychological well-being, especially with those who will be experiencing bullying and being called nicknames. So early treatment have advantages for these patients. On the other hand, there are some disadvantages. For example, if you start early, you will have a longer treatment with more number of appointments, which is a burden financially for the parents. And you will also burn out patients' compliance. And soft tissue that you will need to stabilize the results of your treatment will only mature around 12 to 14 years of age. So you still need to wait until this time with your retention. So to sum up the difference between early and late treatment, the conclusion is that early treatment in the early mixed dentition should be restricted to patients where there is thought to be particular risk of trauma to the teeth, or if they are experiencing bullying or teasing about their malocclusion. So basically, it's important to select your patients for early treatment for them to have a good benefit from the treatment compared to the disadvantages that we talked about. Now, what are the types of malocclusions that could be treated using functional appliances? Again, any functional appliance should be used in growing patients only. And it's mainly used to treat class 2 division 1 malocclusion with a class 2 skeletal discrepancy, mainly where the mandible is retrognatic. Okay? It can also use for class 2 division 2, but we need to modify the functional appliance. In a class 3 malocclusion, the evidence would say, the scientific evidence would say that the growth modification using functional appliances is minimal. And it's mainly the correction of such malocclusion is mainly related to dental movement rather than growth modification. Okay? So the main and the most common malocclusion that we use functional appliance for is the class 2 division 1 malocclusion. Now, are there certain cases where we can use functional appliance alone as a single stage of treatment? Yes, we can. We can have some cases where we use functional appliances alone. And the features for these patients is as follows. If the upper and the lower arches are aligned, or if the upper arch is mildly spaced, because we expect the incisors to retrocline, and the lower incisors are slightly, mildly crowded because we expect the lower incisors to procline a little bit. The other feature is that have main discrepancy in the anterior-posterior dimension, mainly. And we need to aim during the treatment to overcorrect the malocclusion. So, for example, we are not aiming for an overjet of 2 to 4, we're aiming for 0, for example, because then we will end up having during the transition stage some relapse. So during the transition stage, the patient will settle into class 1 malocclusion, class 1 occlusion, let's say. So during the transition stage, after using the functional appliance, the patient can use the appliance nighttime only until the end of the growth period. And this is the classical case where we can use functional appliance alone as the treatment modality or treatment option. But if the patient has other problems and other features of the malocclusion, then it's okay. We can use the functional appliance as a first stage of treatment to modify growth. And then after that, we will have either transition stage or no transition stage. If the patient is in the early permanent dentition, we can move to fixed appliance. And of course, we need retention stage. Usually, if you have growth modification, the retention should continue until growth is stopped. So this is an example of a patient. She's 11 years old and 8 months. Overjet is 9 millimeters. She presented with a class 2 division 1 incisors classification with a class 2 buccal segment relationship, increased overjet and increased overbite. Now let's go to our checklist. Do we have skeletal problem? Yes. Is it in the anterior posterior dimension? Yes, the patient has class 2 skeletal pattern. Is it mainly the mandible? Yes, looking at the nasolabial angle, labiomental fold, it's mainly the mandible that is the problem. Is the patient still growing? Well, actually, she's almost at the end of the growth spurt, looking at the fact that she's a girl, 11 years and 8 months. She's almost at the end of the growth spurt, but still, we still have some growth to modify. So is it a good case to start with functional? Yes, but definitely functional appliance is the first stage of treatment, and it's not the only stage because we have lots of other problems. So this is the classical twin block appliance. This is type of a functional appliance that we will talk about in a minute. And it has an upper block and lower block of acryl, and it forced the mandible forward. Okay, and here we're overcorrecting the overjet. So this is the patient nearly at the end of the functional appliance phase, and having a posterior open bite is a very important feature when patients use twin block type of functional appliance, because this means that the patient are complying well with their treatment and they're wearing their appliance almost full time. So this is an excellent patient with good compliance. This is followed by fixed appliance, no extraction. And this is nearly at the end of treatment. And this is the patient at the end of the treatment. Can we use the functional appliance for class 2 division 2? Yes, as long as the patient has an anterior-posterior skeletal discrepancy. But we need to modify our functional appliance. In the past, they used to have a pre-functional stage for class 2 division 2 cases, where they procline the upper incisors and they convert the patient from class 2 division 2 into class 2 division 1. And then after that, they treat the patient as a class 2 division 1 using functional appliances. Nowadays, we don't have to do this anymore. We can use a single functional appliance that is modified that will do both, procline the upper incisor and posture the mandible forward. So we don't have to go for a pre-functional stage. So this is an example of a patient who's a classical class 2 division 2 incisors classification on class 2 skeletal base with class 2 buccal segment relationship, deep overbite, and classically retroclined upper central incisors and proclined related upper lateral incisors. So we need to modify growth for this patient. Twin block appliance was used, and this is the double cantilever that was added to the twin block as a modification in order to push the central incisors forward. Okay, as you can see, this is the classical posterior open bite when you use twin block with patients with good compliance, and this is the patient at the end of the fixed appliance treatment. So functional appliances could be classified into removable or fixed, and sometimes we can add the headgear appliance to the functional appliance in order to inhibit the forward growth of the maxilla, okay, and sometimes to control the vertical growth of the maxilla as well. So headgear could be added in a certain cases to the functional appliances to aid for growth modification and vertical control. These are the main 5 types of functional appliances that we will talk about. Twin block, Hertz appliance, medium opening activator, bionator, and Frankel appliance. Twin block was introduced by Clark in the 1988, and it was the most popular functional appliance used in the UK. And this is a survey that was done maybe 20 years ago. Still, it is a commonly used functional appliance in the UK. It is well tolerated by the patient. It's a patient-friendly appliance, and it is made of 2 pieces, 2 blocks, okay, an upper one and the lower one. Okay, both parts are fixed together when the patient bites his teeth together using posterior blocks. Okay, so forcing the mandible when the patient bites his teeth together, these blocks will force the mandible forward. It is made of retentive components in order to retain the appliance in place. This may include labial bow and Adams clasps, and of course we have blocks in the upper. The blocks are against the 5 and the 6, and the lower the blocks are against the 5 and the 4. As the patient is biting his teeth together, as you can see, the patient should force his mandible forward in order to have a more comfortable position. The blocks will meet at about 70 degrees of mesial inclination, and the separation should be about 5 millimeters of vertical separation. You can modify twin block by adding, as we said, anterior Z-spring or double cantilever. We can add midline expansion screw as necessary if we want to expand the maxilla. You can add reverse labial bow in the upper or in the lower. It depends on the individual cases and individual needs for the patients for different cases. So this is twin block. As you can see, this is an added midline expansion screw. We have Adams on the 4s and on the 6s. On the 4s, usually Adams are 0.6 millimeter stainless steel wire. On the 6s, it's 0.7 millimeter stainless steel wire. And in the lower, we have double Adams on the 4s and on the 5s. The lower 6s were not clasped because most probably we need for to enhance free eruption of the buccal segment for such patients. The vertical is more than 5 millimeters. It's a little bit exaggerated for this case. So these are the two blocks, the upper one that is against the 5 and the 6, and the lower one that is against the 5 and the 4. Of course, this appliance can be worn full time, and it can be modified, as we said, to treat class 2 division 2 malocclusion. If you need further activation in the middle of the treatment, then you can add some ready-made buttons, acrylic buttons, to the upper block in order to enhance forward posturing of the mandible. We can add acryl to one of the blocks, the upper or the lower, and you can actually enhance forward growth of the mandible and posturing of the mandible. After proper using of the twin block, as we said, you will end up having posterior open bite. In order to solve this problem, there are 3 ways to do it. Number 1, use the same appliance nighttime only. Number 2 is to trim the upper block gradually and allow the lower buccal segment to erupt freely into the space. And number 3, to move directly to fixed appliance and to actively extrude the teeth into this space. The other type of functional appliance is the Herbst appliance, and the Herbst appliance is a fixed type of functional appliance, and it was introduced by Panthers in 1979. It's a myodynamic, and it is tooth-borne. As you can see, we have tube and pin, and the splints are cemented to the maxillary and the mandibular arches. And these tubes and pins are held at each end, holding the mandible forward, rigid advancement of the mandible. And then for the rest of the teeth, you can add fixed appliance as necessary. So this pin and tube will force the mandible forward. Now, although it's easy to eat with this appliance and easy to talk, and the patient's compliance, relying on patient compliance is reduced, yet this is an expensive appliance to construct. And if there were any breakages, and there will be breakages because there's a high rate of breakages for such an appliance, then it's expensive to repair, and you need to have custom-made parts to reinsert inside the patient's mouth. Nevertheless, although it's fixed, but it is as effective in terms of correcting the malocclusion as the twin block, and reducing the overjet and correcting the malocclusion. But the Herbst appliance is better tolerated compared to the twin block, because the twin block is like a mouthful appliance compared with this small piece of metal that is banded to the buccal segment. The third functional appliance is the medium opening activator. Okay, if you remember, this is the Andreessen's original activator. Okay, this was modified into this less bulky appliance, monoblock, that is called medium opening activator. It is made of an upper and lower acryl, and it is joined together with rigid acryl with a breathing hole anteriorly. So the anterior part of the acryl is left open for breathing. Okay, so we have the upper part of the acryl covering the palate, and the lower part of the acryl is made into lower incisor capping and a small lingual extension, not this huge lingual flanges, and more retentive components. So we have a labial bow in front of the upper teeth and palatal bow posterior to the upper teeth, and then we have Adam's clasp on the buccal segment. So it's a more retentive appliance compared to the original one, of course. So we have lower incisor capping and lower lingual flanges in order to force the mandible forward. There are no lower molar capping, so they are free to erupt. So we need to be careful when we use the medium opening activator. It is used mainly in patients with reduced vertical proportions and deep bite. So it is used, of course, for patients who have a small mandible, where we want to enhance the forward growth of the mandible in a class 2 skeletal pattern. And in addition to this, the vertical proportions should be reduced because this appliance is very efficient in allowing free eruption of the buccal segment, and this will enhance the vertical growth and vertical correction for these patients. Now, the limitation is that it's not like twin block. Twin block and herps can be, of course, fitted 24 hours. They work 24 hours. But the medium opening activator can only be fitted for about 14 hours, okay? The other limitation is that, again, not like twin block. Twin block we can modify by adding midline expansion screw, but here we cannot add midline expansion screw because it's a monoblock. Okay, so if you need expansion, you need to go for a pre-functional stage of expansion followed by the functional stage. Now, I lost count. Maybe this is the last one. This is bionator. Oh, no, this is number 4. Bionator, introduced by Walters in the 1960s. And as you can see, compared to the activator, there is no acrylic coverage for the palate. Instead, we will have a palatal wire, transverse palatal wire with a cuff and spring. And the labial bow is modified into a long transverse loop that will push the cheeks away from the teeth. And we will have lower incisor capping, okay? So the transpalatal wire here will push the tongue down, so it will modify the tongue behavior. And it will increase patient comfort by lacking the acryl in the palate. The wire that is made that is making the palatal cuff and spring is usually made of 1.2 millimeter stainless steel wire, while the labial bow is made of 0.9 millimeter stainless steel wire. Okay, these modifications of the labial bow is called buccinator bows, and the idea of the buccinator bows is to push the cheeks, the buccinator muscle, 3 to 4. It is positioned 3 to 4 millimeter away from the teeth. And the idea or the theory behind this is that we eliminate the effect of the cheeks on the buccal segment, and we expect, therefore, some expansion, spontaneous, passive expansion of the buccal segment. It will reduce the acrylic bulk compared to the activator, and it uses much smaller lingual flanges, so it's more comfortable. And there are minimal interocclusal acrylic to prevent or guide eruption. Okay, so this is compared to the activator. The last appliance that we will talk about is the Frankel appliance. It was introduced by Frankel in the 1960s, and it is called FR. It could be relative to Frankel or function regulator, okay? And it is the only completely tissue-borne appliance. So most of the components will not be aiming for any dental effect. It's mainly tissue-borne appliance. And it is made of a framework of metal with lingual shields of acryl, buccal shields of acryl, and lip pads. Okay. Frankel made 4 versions of his appliance. Frankel 1 for class 1 mild, class 2. Frankel 2 mainly the one that we are talking about for class 2. This is the functional appliance that is mostly used. And Frankel 3 used for class 3 malocclusions. Frankel 4 used for anterior open bite and bimaxillary cases. Frankel 2 is different from Frankel 3, if you can see here, by looking at the labial bow. In Frankel 2, labial bow is fitted on the upper incisors, and lip pads are fitted against the lower incisors in order to reduce the effect of the lower lip on the lower incisors. In contrary, in Frankel class 3, Frankel 3, The lip pads are in the upper to prevent the effect of the upper lip on the upper incisors, and then the labial bow is fitted on the lower incisors to correct the class 3 malocclusion. So this is the main difference between Frankel 2 and Frankel 3. The one we're going to talk about that is used to correct the class 2 skeletal pattern by enhancing the forward growth of the mandible is mainly Frankel 2 type of appliance. So the lingual pads that are used here are mainly used to guide the mandible and to posture the mandible forward. The buccal pads here are used like the bionator, are used to push the cheeks away from the teeth in order to enhance the passive expansion of the arches. And the lip pads here are used to avoid and prevent a lip trap and to prevent the effect of the lip on the incisors and allow some spontaneous proclination of the incisors. All wire components of Frankel appliance should be 2 to 3 millimeters away, of course, from the alveolar mucosa to prevent trauma and ulcers. This appliance is difficult to wear. It's a mouthful appliance. The patient cannot wear it 24 hours. It's hardly 12 to 14 hours. And it's expensive to make. You need to have a highly talented technician to be able to make with such efficient metal framework that are connected together with this acrylic. And if it's broken, then it is really difficult to repair. So nowadays it's rarely used, but it's important for you to know that this is one of the types of functional appliances are used, and you need to make sure that you can differentiate between Frankel 2 and Frankel 3, or function regulator 2 and function regulator 3. Right. So we said sometimes we need pre-functional preparation, for example, to push the upper incisors forward in class 2 division 2 or to go for expansion. So this appliance is called ELSA. ELSA means expansion and labial segment alignment. Expansion and labial segment alignment. ELSA appliance is sometimes used before functional appliances, especially if you're using medium opening activator. But if you're using twin block appliance, then this is not necessary. You can add the expansion screw and you can add the reverse labial palatal loop with the same functional appliance. Okay. So how can you prepare the patient to fit functional appliance? You need to take proper records, upper and lower impressions, alternate impressions. You need to register the bite where the patient is biting his teeth almost edge to edge. So again, we are not aiming for an overjet of 2 to 4 millimeters. We're aiming for overcorrection. We want the overjet to be 0 at the end of the functional appliance treatment. And then during settling and the transition stage, then we will have some relapse and we will end up having 2 to 4 millimeters of overjet, which is the normal. So we take the bite edge to edge, if possible. Sometimes the patient's musculature is too tight and it's too difficult to make such bite edge to edge. So we can take the about 70% advancement of the mandible in relation to the overjet, so 70% reduction of the overjet in the first bite, and then during treatment we can further activate the advancement of the mandible so that the patient compliance will improve and not to stretch the musculature too much. So this is the way to take the bite. We can use what we call frog-shaped wax or a horseshoe wax. We can use this beautiful tool to guide the patient into edge-to-edge position, and then these flanges are actually having holes in order to add the wax and to register this bite. We can use tongue depressors in order to separate the teeth to have the 5 millimeter separation vertically and enough space for the blocks to be built or the functional appliance to be different components to be added. So again, is there a difference between full advancement of the mandible compared to having incremental advancement of the mandible? There is no difference. It depends on the patient. Can they comfortably advance their mandible forward edge to edge? If yes, then we take the full advancement bite. If not, then we have to go for incremental bite. There is no evidence that there is difference between them in terms of the efficiency of treatment. Now, the functional appliances that should be worn 12 to 14 hours are the medium opening activator, the bionator, and Frankel. But appliances that could be worn full-time is the twin block and the Herbst appliance, of course. To start off with, removable functional appliances should start 2 to 4 hours a day during the evening, and then we increase this time gradually until we end up with the proper time required according to the appliance. We need to advise the patient that we need to warn the patient that this is not really a painful appliance, but they will experience some difficulties and discomfort when they start to use it. Okay, we need to have good motivation, because good motivation means that the patient is going to wear the appliance. The patient is going to wear the appliance. That means that we will have some efficient correction of the malocclusion. When we fit the appliance, we need to see the patient 2 to 3 weeks after that to check compliance, motivation, correct use of the appliance. And after that, we can, if everything is okay, then we can see the patient every 6 to 10 weeks. Okay, every time the patient comes to the clinic, we make sure that the retentive components are retentive, we activate them. If we need to activate the active components, for example, the expansion screws, the labial, the double cantilever, etc., then we activate them. And every time the patient comes to to his appointment, we need to check the amount of overjet. We need to check the reverse overjet. What does that mean? We ask the patient to posture his mandible as much as possible forward, and then we measure the reverse overjet. And then every visit, we ask again the patient to posture his mandible forward. If the patient is wearing his appliance properly and there is good progress, then we need to see that the reverse overjet is increasing. It's getting better. It's getting more reverse overjet. The mandible could be postured forward further. Why we're doing this? Well, because sometimes if we measure the overjet, it's not really measuring the real result, because the patient was wearing the appliance, so he is used to posture his mandible forward, maybe unconsciously. So if you ask the patient, bite your teeth together, then they will bite edge to edge, because this is what they used to do the previous 2 or 3 months. So sometimes it's not reliable to measure the overjet, so we go for the reverse overjet. We look for the overbite. We, of course, measure and examine the molar and the canine relationship. If there is no progress, that means the patient is not wearing his appliance, because we know that although this appliance is not great at modifying growth, but there will be some dental effects at least. There's 73% of overjet reduction that is dentally. So if there is no progress whatsoever, that means the patient is not wearing his appliance mainly. Maybe there is lack of growth or unfavorable growth rotation, but still, at least we will have some dental effect, as we said. Maybe there's a problems with the design of the appliance or fitting of the appliance, etc. But we need to know that there is a failure rate using functional appliances about 20 to 30% of the cases, okay? And compliance better with younger patients or fixed appliances. So if it's fixed functional, maybe it's of a better compliance. The younger the patient, the better the compliance is. Now, as we said, we need to aim for an overcorrection, edge-to-edge relationship. And then when we reach to our aim, then we need to think about the transition stage. As we said, we can go to nighttime only of the same appliance. For about, if we're not planning for a second stage, then we have to use this appliance nighttime only until growth stops or ceases, slow down. If we're aiming for a second stage of fixed appliance, then we need to use the same appliance nighttime only 3 to 6 months, and then move to a fixed appliance stage. So just to remind you of the functional appliances, our aims of treatment using functional appliances is a profile improvement. We are trying to modify growth. We are trying to improve the skeletal discrepancy. We are aiming for correction of the overjet and the overbite. We are aiming to correct the buccal segment relationship in the anterior posterior and in the transverse dimensions. And we are aiming to alter soft tissue environment to a more favorable position. Functional appliances are indicated mainly for growing patients, of course, motivated patients, patients with mild to moderate skeletal class 2 base, patients with a class 2 division 1 malocclusion mainly, or for an interceptive reduction of overjet for patients with an increased risk of trauma, or we can use it for anchorage preparation for patients with a class 2 molars. Now, the classical case to use functional appliance only, as we said, are patients with the class 2 division 1 malocclusion and mild to moderate skeletal class 2 base, mainly due to retrognatic mandible. well-aligned arches or mildly spaced upper arch and mildly crowded lower arch, increased overjet with the proclined upper labial segment, lower labial segment of average proclination. There are some contraindications, of course, patients who are not growing. Patients with a class 1 skeletal pattern but a class 2 molars. We don't use functional appliances for these cases. Patients with asymmetric molar relationship related to local factors and not skeletal factors. There are some cases that can be difficult to treat, so we need to be careful. Patients who are high angled, patients with anterior open bite, backward growth rotation, cases with lower labial segment being already proclined. So these are difficult cases to treat. It's not a complete contraindication, but we need to take certain precautions. So this is the main headings that were covered in this lecture. Thank you for listening.